So celiac plexus block, I'm just running through, Sushma will be talking about it. The point I wish to make here is, this is the anterior border of the vertebra. The needle tip is always much more ahead in a celiac plexus block because you have to go in front of the aorta for this purpose. Patient after celiac plexus block, happy. The difference, many people keep asking me, is what is the difference in needle placement between sympathetic ganglion block and celiac. Sympathetic ganglion block is done just at this part, just in front of the vertebra, whereas celiac comes well in front of the vertebra. That is the difference. This is hypogastric block spread. I won't joke. So the blocks, other blocks which we do are into joints, bursae, etc. Facet joint, knee joint, acromioclavicular joint, etc. The facet joints are this way, and the needle is placed in under a image guidance. I'm working out to do it under USG, and I can tell you it's quite difficult because when I think that I am in there, actually I'm in there. It's a chink which is seen, so some more of learning curve I have to pass through. Another injection which is done called the pars or interarticularis injection is at this spot. That is called the neck of the Scotty dog. This is where in spondylolysis, they have a crack here, and these patients have severe back pain. Let's hope that this one works. I have developed a technique for doing injections for OA knee. There are many patients of OA knee who do not have much of bony changes, and good orthopedic surgeons and knee replacement surgeons will never touch them. They will always tell them, go and come back when the pain is unbearable. What does this poor patient do? Already he has got bad pain. He has to wait till it becomes unbearable. So for this category of patients, all knee pains start out as a degenerative inflammatory pain. But then after a while, it assumes a neuropathic character, and that is where doing injections into the nerves around the knee helps tremendously. There is a paper by Johns Hopkins where they have described the nerve supply to the knee joint. After reading that, I have developed this innovation, and I'm happy to say that I must have treated more than 50, 60 patients with this who are doing quite well. There are some who do not do well, but that percentage is rather low. Here I would like to replay this just to show you. This is the sartorius. Here Dr. Gopal was mentioning that the twitches which come are actually vastus medius. I would like to differ here. There are twitches. I have put the probe on the vastus medius, and the twitch comes actually from the sartorius. It is the saphenous nerve which seems to be variant in many, many patients. It goes through the sartorius rather than forming the well-described subsartorial plexus. Okay, this is another patient where I'm doing an acromioclavicular joint injection, clavicle, acromion. See the difference. Much widened in this gentleman. Doing an injection here with acromioclavicular joint injection and subdeltoid bursa injection. This is the deltoid. This is the supraspinatus. This is the area of the subdeltoid bursa which communicates with the main joint and many other areas. And injecting into this relieves frozen shoulder pains instantaneously almost. If I do a combination of acromioclavicular, subdeltoid, and then the bicipital tendon here, the patient who comes in with severe restriction and severe pain is pain-free on the day of injection. However, they require treatment further for other considerations, but that is how quickly we can relieve a patient of frozen shoulder, which is supposed to run a natural course of 1 to 1.5 years of severe pain. I don't think these videos are playing. I'll try anyway. No, it's not playing. So the other things we do, this is the lumbar plexus block outline, which Sandeep was talking about. We do it very often for failed knee surgeries. After a TKR, the patient says, I was much better before the TKR, I'm worse after the TKR. This is a particular subset of patients who goes for severe neuropathic pains, almost going up to reflex sympathetic dystrophy type or complex regional pain syndrome patients. So for them, we approach the lumbar plexus so that we can give them pain relief, and then I do another treatment called dry needling of the muscles. So when a patient comes with RSD of hand, we do the brachial plexus block, infraclavicular brachial plexus block. And some of the other simple nerve blocks are when somebody comes with a multiple fracture rib, we do a paravertebral block, pass a paravertebral catheter. This is a very senior anesthetist's mother. This is how she came. Paravertebral block. 1 day later, this is how she is. So some of the procedures done in pain management are awesome in that I am actually awed by their power to relieve pain. It's wonderful to do it. So anyway, I think I'm running out of time. The catheters, I think I was already talking. This is a lumbar plexus catheter, continuous stimulating catheter being passed, needle catheter being stimulated. Later, the catheter being stimulated after being positioned. Herpes is another condition which we can relieve quite immediately by a paravertebral block like this. A senior surgeon's wife, like this when she came, happy within half an hour. After CABG, many patients have a lot of pain in the sides and in the intercostal spaces. This is passed off as costochondritis. Though there has been no evidence to indicate an inflammation or infection of the costochondral joint. It is referred to as costochondritis, but it is actually a severe spasm of the intercostal muscles. This, when we do a paravertebral block, it is relieved very well. So somatic nerve blocks, okay, this is how a patient of complex regional pain syndrome comes after minor trauma or after a fracture or whatever. This man totally disabled by bilateral CRPS. Hands like this, they come like this, overgrown nails, hot hands, and swollen, very, very stiff. This is a disease of stiffness. They just can't make a fist like this. If you ask them to make a fist, they can do only this much. When they can do only this much, that means the functional efficacy of the hand is just not there. So again, brachial plexus block, sympathetic ganglion block, and after treatment, this is how they are within a month. That is, when I say within a month they recover to this level, it is nothing short of a miracle for these patients, because CRPS is a condition which is dreadful, where the hand is lost forever for functionality. This is another cancer patient with a continuous posterior approach brachial plexus block. For cancer breast, you have to go for the posterior approach, because elsewhere, for all the other traditional approaches of brachial plexus, you have problems of nodes and other things. This lady came to me with severe pain, but with this, she was so comfortable. When she died 3 months later, her complaints were everything other than pain. So anyway, so new techniques, equipment, and knowledge keep going up and up in our profession. We have no choice but to keep up. Maybe that way we will avoid Alzheimer, to quote, and innovate every day so that we benefit our patients. And then most importantly, what we are all doing today, teach many so that many more may reap the benefit. Thank you very much.